It's always very interesting to see a lecture theatre fill up from the back, and the seats at the front are always the last to be taken. Well, good evening, ladies and gentlemen. On behalf of the university, it's a very great pleasure to welcome you here this evening to one of the major events, a public lecture series that forms part of Lancaster University's 50th anniversary celebrations. Now, while the university is celebrating its 50th anniversary this year, our interests in end-of-life care, palliative care, are rather more recent. In fact, it's only, I think, in the last 10 years or so that we established what's called the International Observatory on end-of-life care and developed our interests in this field. And I think over the last few years, what Lancaster University has done, thanks to a number of colleagues in this room and some who aren't here this evening, is really to establish, I think, quite a significant reputation nationally and internationally in this field. So we thought it was highly appropriate that we should organise an event to celebrate this. So you'll have seen from the posters outside quite a large number of very high-profile research projects that colleagues have been working on, and more recently we introduced a taught doctorate in palliative care, and it's a great pleasure to see some of the students who just enrolled on that degree programme here this evening as well. I think you can hardly open a newspaper or switch on the television without seeing something relating to end-of-life care. So it's a subject that's highly topical, as evidenced by your interest and attendance this evening. So a very warm welcome to you. But I'd also particularly like to thank the 50th anniversary organisers, so a lady called Becky Gordon, who's just at the back, who has helped put the event together, but particularly Catherine Walshe and her team in the Division of Health Research, who played a major part in making this evening happen. And I'd particularly like to thank and welcome the three speakers who are with us this evening for their contributions, which we're all looking forward to enormously. And the batting lineup, which I think for those of us who follow cricket is an appropriate but rather dismal metaphor, the batting lineup is, I think, first of all, Professor Dame Barbara Monroe, who is going to speak initially, followed by, I think, Catherine Walshe, and then Sue is going to finish wrapping things up at the end. Then there'll be an opportunity for you to ask questions and for some discussion, and then we'll wrap this up with some refreshments at the end of the evening. So without further ado, a warm welcome, please, to Professor Dame Barbara Monroe.
Just get myself mic'd up. And while I do, I can take the opportunity to say good evening, everybody. And what a real honour it is to be able to be here this evening to speak in celebration of 50 years of a completely wonderful university. And it has been one of the great privileges of the last few years to have been an honorary professor at the End-of-Life Observatory here. It does remarkable work. What I want to do in the next half an hour is to outline some of the challenges in making sure that everyone gets good care at the end of life, what some of the responses to those challenges might be, and to think about and try and convince you of the fact that if we're going to get to that place, that nirvana of everyone getting good enough care at the end of life, whatever bed they die in, it is all our responsibilities. It cannot sit solely with professionals, nor solely with individuals or communities. So Dame Cicely Saunders, widely credited with starting the modern hospice movement, founded St Christopher's in 1967, and I think it is interesting to reflect that the inpatient unit opened in 1967, but a 24-hour, 7-day-a-week visiting service started only 2 years later. Founded, as we all know, on the principle of really thinking about individuals about their total pain, not just their physical pain, and thinking about family and friends and support through the illness and into bereavement. Based from the beginning on care, backed up by research and education, because Dame Cicely recognised that hospices themselves would never be able to, nor should they ever, deliver care to everyone at the end of their lives. There's been a significant and rapid expansion of hospice care. There are over 220 inpatient unit hospices in the UK, 260 home care teams, over 300 hospital support teams, and hospice initiatives exist in over 120 countries. But from the beginning, there has been the sense that hospices only ever look at the tip of the iceberg of need. Professor John Hinton, who in the same year that St Christopher's opened wrote a seminal book called Dying, and indeed he continued to do research, particularly into the needs of people being supported at home at St Christopher's until his death. But he wrote in '67, "We emerge deserving of little credit, we who are capable of ignoring the conditions that make muted people suffer. The dissatisfied dead cannot noise abroad the negligence they have experienced." The terrible thing is that we're still ignoring the conditions that make muted people suffer. Douglas said rather memorably in the early 90s that hospices provided deluxe dying for the privileged few. The WHO definition of palliative care talks about impeccable assessment and treatment of pain and other problems. And yet we know that many people don't get an assessment at all, let alone impeccable treatment. And rather ironically, in 2010, the Economist Intelligence Unit ranked the UK top for quality of death, only to be followed in the next 4 years by a raft of horrendous documentaries, investigations, and government reports about really serious deficits in care. Of course, resources matter, but many of the deficits appeared to be as much about attitude. The Palliative Care Funding Review in 2011 indicated that there was still huge unmet need. In England, it was estimated that about 150,000 deaths every year would benefit from specialist palliative care but didn't get it. Globally, in 2012, estimated that 22.4 million people need palliative care and that 18 million died with little or no access to pain treatment. And I'm sure many of you will have heard the reports on the radio and the TV, reports of people throwing themselves in front of trains and lorries to get away from the pain they were experiencing. Pain that is largely unnecessary. Morphine is not that expensive. It's a question of restrictive government regulations. It's a question of unnecessary fears of addiction. And it's a question of needing different approaches to training healthcare professionals. So it's clear that our current approaches are insufficient. There are rising expectations of healthcare. There's a continued disparity between what people say is their preferred place of death and where they actually die. In the UK, over 50% of people still dying in hospital, although the numbers dying at home are increasing. Little change in public and professional attitudes in terms of a reluctance to openly discuss death, dying and bereavement. We're facing everywhere, not just in the UK, significant social change and the challenges of providing culturally appropriate care. Social care continues to be the poor relative. Both the Dilnot Review and the Cavendish Review looked at the difficulties of integrating health and social care. And Marmot showed us that social disparities in healthcare outcomes are widening. In the UK, it's clear that the wealthier you are, the healthier you are, and you will die younger if you suffer from poverty. There's also a postcode lottery in the amount that's spent on end-of-life care across the country that's a national shame. We're surrounded by the rhetoric of choice and individual autonomy, backed up against the reality of need, demand, and constrained financial and professional resource. And in this country, all in the context of a recession and unprecedented change in the NHS. But when I speak to members of the public, I think they want reliability I think they can understand rationing. I think people want to know that if you say you will visit on Thursday, you will visit on Thursday. And if you say you will visit at 10 o'clock, that you will visit roughly around 10 o'clock, give or take half an hour. They're not saying that you've got to visit every day of the week. I thought it was very interesting in the latest round of publicity around new drugs for cancer, that on this occasion, and I checked the blogosphere as well, we didn't have a public outcry about why has Wicked Nice said that people can't have this very expensive drug. What we got was the beginnings of a public outcry about the behaviours of the big pharmaceutical companies. We need to think differently about funding the NHS. And this isn't so much a comment about end-of-life care, it's a comment about how we manage our National Health Service. We've got governments who are more interested in getting themselves re-elected than the realities of whether we can really deliver against increasing need a background of continuing cuts. We need to do something pragmatic and realistic. Are we going to increase national insurance? What use are we going to make of taxes? Or are we going to have a top-up kind of NHS where you get a sort of vanilla service that if you can afford it, you can top up and pay more for? We need a public conversation about the kind of NHS we want. Robert Twycross quite memorably said of the hospice movement that movements can become monuments. Well, I think that's true of the NHS as well. So there's a challenge, both for end-of-life care, but also for the National Health Service as a whole. We do have to ask ourselves whether hospices are getting in the way. Are we complacent, over-engineered and overpriced? And we've been accused of being all of those things. Have we made a specialism out of a generalism? The reality is that most services will do some things that are specialist and some things that are generalist, and what we need to do is act in concert to meet need. We need to stop arguing about what's specialist and what's generalist. Do producer-driven interests dominate in hospice, alongside the inertia of the way we do things? And certainly I've got an awful lot of colleagues who like to do the things that give them pleasure, rather than the things that really need doing. How do we champion and respond to the voice of need and avoid defending history or a particular form of supply? To be relevant, hospices must partner with the wider system, and they've got to think about service models that are less demanding of resources than the current ones. They've got to think about populations as well as the needy individual in front of them. They need to provide evidence of outcomes and value for money and create much better research partnerships, and that's why Lancaster is such a vibrant example of this, of research that is absolutely linked to practice and to outcomes. And to do that, we need standardised data. Australia puts us to shame in their use of standardised data and their ability to benchmark so that people can really be challenged by and learn from the best. And the best isn't always the one that is most resource hungry. What we think we know is going to change. Unmet need is going to rise, and there'll be new populations with new needs that require new services. We're going to see more deaths in late old age, fewer carers, more cancer, more dementia, people with multiple chronic illnesses, and many more people living in single-person households. By 2035, over 85s in the UK will account for over half of all deaths. And with that piece of data comes the reality that frailty will become increasingly important. Older people with a mixture of health and social care needs. There'll be an increased demand for beds as disability increases. And Jane Seymour has written interestingly about the need to develop proactive and preventive palliative care rather than reactive. On the whole, palliative care gets involved when referrals are made to its services. It needs to think about itself differently. We will begin to need to see advanced care planning as the norm, as something that's anticipatory but repeated, ongoing. And we still suffer from the problem of the cancer script. Indeed, some research work that's emanating from Lancaster has shown how the battle metaphor has regained some control since its first emergence in the 70s. And the battle metaphor, which then kind of sinks into the victim when the clearer trajectory of cancer reveals itself and the fight is now over, is a metaphor that doesn't translate well into the kind of communications that we need to have with frail older people who have multiple chronic illnesses. We have a very crude understanding of what people's preferences are really about as they come towards the end of their lives. There's been this huge emphasis on place of death, as if that really matters. What really matters is where you do most of your dying. The precise place where you die is often a little bit influenced by random events towards the very end of your life. What matters is where you do most of your dying. And the kind of trade-offs that people make. Many older people do worry about being a burden on their families. That's not just part of the euthanasia debate, it's real for older people. And many of them are willing to trade off some comfort and familiarity for access to really good symptom control as they come towards the end of their lives. 24/7 services are essential, and I'm shamed by how many of the services across our nation that tout themselves as 24/7 services are nothing of the sort. There's sort of telephone access for professionals across 24/7 and a sort of reluctant little ever so emergency service that you might get if you really had somebody in the know who jumped up and down and shrieked on your behalf. And what about district nursing? Evidence just this week from the Royal College of Nursing that it is in terminal decline. If we aren't going to restore it in terms of its training and its availability and its respectability, we're going to have to come up with a dramatic alternative. Others will talk about the commission that was initiated by Help the Hospices about future ambitions for hospice care. But it is, if you haven't read it, freely available and really worth reading. And it emphasises that services need to be flexible and adaptable, and that hospices in particular need to be collaborators and partners at scale. And we really need to work on the competition trust issues. And foundation hospitals in particular need to take a lead around trust and around reducing competitiveness, because much of the competitiveness is driven by them. So, final bit about hospices, they need to reach more for less, and in doing that, they often will need to act as a hub. We know that access to specialist palliative care brings benefits, and I'm sure Catherine will say more about that, but there is sound research to demonstrate that. So hospices need to be delivering good enough, cost-effective, evaluated care and service innovation, easily accessible to those most in need. And I wonder how many hospices know whether they're delivering their services to those who are most in need. They need to support the development of a competent and confident workforce and spearhead efforts to change public attitudes. In all of this, hospices must do the difficult and hold fast to the disadvantaged. I don't want to hear of a hospice that can't admit somebody who is actively suicidal, because they don't do that sort of thing. Because if they, with their expertise and their resources, can't do it, I'm not quite sure what service can. And we need to carry on doing the difficult and holding fast to the disadvantaged, because there's sound evidence from the United States that for-profit hospices, and they exist multiple times over in the US, cherry-pick the easy-to-manage cases. I like Charles Ledbetter's statement about what hospices need to deliver: intimacy at scale. And the scale point is really important. Together, health and social care providers need to support the drive to the community. We're going to have a national choice offer. The choice is going to be that you can die at home if you want to. So bad luck if your choice was something else. But it is right that we should have as many people dying at home as possible, whilst also recognising that a home death isn't necessarily a good death. It's only a good death if it's got the right supports in place. So I think all healthcare providers, and I'm no longer talking about hospices in particular, need to think about coordination centres for people coming towards the end of their lives. And by that I'm talking a year, 18 months, 2 years, rather vaguely, people who need health and social care coordinating. We need to think about the development of personal social care services and about the fact that personal budgets are going to be more and more live within our healthcare system as they already are within our social care system. We've dipped our toe in the waters of recruiting and training our own personal social carers at the hospice where I work. And the improvement in hospital admissions avoided, in home deaths, we're up to 75% home deaths where we deliver integrated health and personal social care, and in the perceived quality of the service, both from the actual patient and family or informal carers, has been quite dramatic. The change for the social carers, the personal carers, has also been dramatic because they get a great training that has a qualification attached to it and they get supervision. So they feel a sense of pride in their work rather than being the person who's paid rock bottom and doesn't get travel time and is pilloried in the press. We were visited by the Cavendish Review, who were surprised when they looked at our adverts for recruiting personal social carers that we just said that we wanted to recruit kind, reliable and committed people. And they said, don't you care about their previous experience? And we said, well, we can train people in manual handling and the delivery of medications. What we can't train is kindness and reliability. So that's what we advertise for. And I think it's sad that a client can say of her social carer, he's such a well-mannered boy and that's healing in itself. I don't know how some of my other carers got employed. It's sad when being well-mannered is something that is singled out for special comment. All services need to think about being involved longer with people, but probably more sporadically. And that means we're going to need to rethink our professional assumptions. Doctors in particular, who like to know who's on their caseload and a feeling of responsibility for the care of the people on their caseload, it's going to be a bit more in and out than that. We need to think about rehabilitation and survivorship and sweating resources. The NHS and hospices are both far from being 24/7 organisations. We're using our own hospice facilities now on Saturdays and Sundays and doing a lot of work around rehabilitation, survivorship and work with young people in transition, so that the building is literally being used 24 hours, 7 days a week. And that's what the NHS has got to do as well. We need to maximise skills transfer and support beds everywhere. The sector that probably most needs support and skills transfer is the care home sector. Care homes now look after much frailer people with much more complex conditions, and yet they receive very little skilled medical and nursing support. The average geriatrician spends only less than 10% of his time outside the acute hospital setting. That's staggering. And care homes are now regularly managing extremely complex symptom control problems and complex ethical situations. So they need the availability of clinics on site and consults from specialists coming into site. And we need to share our resources with them. We've been sharing our creative therapies and access to liaison psychiatry for some time. We need to think about how we triage advice so that places that are open 24/7, which could be hospital, specialist geriatric facilities, or it could be hospices, can give advice across 24/7 to care homes. And we need to recognise that hospital isn't going to disappear. Many people will appropriately die in hospital. And what will that look like? We recently rented a ward in a local acute hospital because we were refurbishing our inpatient unit. And it was fascinating. In terms of patient outcome measure feedback, patient-reported outcome measure feedback, these scores were almost identical. We scored lower for family feedback because they really missed the availability of privacy on the hospice site and also the greater availability of the multi-professional team. But from the patient perspective, almost identical. Can we get to a place, maybe, in terms of thinking imaginatively about how we train staff, where hospice staff would migrate into a hospital palliative care bedded unit and the hospital staff would rotate through into the hospice? It would be good news all round. And how are we going to improve the availability of nurse-led beds, of respite care and step-down care, of those cottage hospitals that we all used to know that closed and are now going to open again? And how will we make sure that we continue, as resources get squeezed, to pay attention to carers and to psychological and social support? It's just a picture of, we've been running schools projects for a long time, but one of the things we try to do is create long-term relationships between the kids who do our schools projects with patients to learn about death and dying, create long-term relationships between the schools and care homes. So we've got a number of care homes now where there are choirs that are ongoing, nothing to do with the hospice anymore, where the schools and the residents have a regular choir. We need to develop a flexible workforce fit for future purpose. The specialist workforce is ageing. Loads of people want part-time working, and we just need to think creatively about how we make that possible, whilst at the same time, if you work part-time, creating the possibility of flexible working that meets a 24/7 rota. And that means thinking societally, not just about healthcare and social care services, but about childcare, about what kind of society we really want to be. The future workforce is going to have to work across settings. That's demanding. Most people don't like doing it. They're going to have to work where they're most needed. We're going to need a change in attitudes, and training can help drive that. But it can only help it if we get in at the beginning. End-of-life care needs to be compulsory in all pre-qualifying training. In a big London nursing teaching hospital with a big school of nursing, until very recently, end-of-life care was an optional module and less than 1 in 10 students chose to undertake it. That is outrageous when you think about the curve and the number of deaths that we're going to see in the future. In particular, and the Cavendish Review highlighted this, we need good training for support workers that's nationally validated and portable. We've got to learn to use our most expensive resources to greatest effect and to really respect and value those grades 1 to 4 posts. Hospices, and they are now, with Help the Hospices support, going to be developing some training consortia where we can have common, nationally validated education products that we just share freely with one another. No more reinventing the wheel. And training needs to change. I was lecturing a group of 50 young specialist palliative care registrars the other day, and I asked them how much training they'd received in dementia. It varied from 1 day to 2 days. But that is a huge part of what they're going to be doing in the future. Pain management tends to be something that's done by yet another specialism, not by palliative care specialists. And that's not going to be possible looking into the future. And we need doctors who want to work in the community. We need district nurses and clinical nurse specialists who are interested in health literacy and how we develop it. And above all, if we're going to be looking after a frail older population, we need generalists. We need generalists in our hospitals. Older people don't slice up neatly into all those multiple specialisms where nobody, and patients talk about it all the time, nobody holds all the cards at once. Nobody's even really looking at the cross medications. We need better links with geriatricians, cardiologists, and so on. And we need, in the training of our young clinicians of all professional groups, to absolutely emphasize clinical leadership in developing services. We need to stop being paternalistic about patients and families and start trusting their ability to talk to one another. And that means community engagement. Volunteers are going to be key to resourcing change. And the biggest hindrance, as I see it, to really creatively developing volunteering is the attitudes of professionals. We've got to stop talking about volunteers can't do jobs that would be done by a paid person, because the future economy will see people moving very fluidly from volunteering roles into paid roles and back again. We need to remember that older people are active, that younger people use volunteering as an entry to paid employment. Lots of our young volunteers at St Christopher's are now going on to become social carers, paid social carers. There needs to be good validated training for volunteers because it improves diversity, if nothing else. And you can see that when we undertook good validated training at the hospice where I work, suddenly, instead of every volunteer being white and between 65 and 75, and they are very useful, we got 37% under 48, 40% male, and 28% from black and minority ethnic communities. We need volunteers in care homes and supported housing. We need to let volunteers undertake mentoring and management roles, otherwise volunteering itself can be too costly. And we need a whole variety of roles. Volunteers in the community with patient-facing roles, doing information signposting, benefits advice, bereavement, transition, housework, and my own particular bugbear, handymen. It's ridiculous that some frail older people have to wait 6 weeks for an OT assessment and then another 6 weeks for somebody to come and put a bath rail up. You know, really, if it was your mum or dad, you'd just get a screwdriver and buy one off Argos and put it up. We've got to stop being so risk-dominated. And volunteers can undertake research roles. Many of the big research trials that we've conducted at St Christopher's, including randomised cluster RCTs and so on, would not have been possible if we hadn't had volunteers managing the data for us. And in these sporadic interactions with frail older people, maybe volunteers can act as the continuity. We need to involve communities in service development and keep our eye on international examples of good volunteering. And many of you will know about Kerala in southern India and the fact that their palliative care services are actually driven by volunteers who call in the professionals as needed rather than the other way round. How do we help people make decisions about treatment options and quality of life? The PRISMA survey in 2011 surveyed 9,000 people across 7 European countries and asked them their priorities if they had less than a year to live. 71% wanted to improve their quality of life, 4% wanted to extend their life, and 25% rather optimistically wanted to do both. But actually, you know, people are reasonably realistic when the chips are down. And to avoid a tragedy like we see in the US with ridiculous overtreatment, driven by an insurance-dominated, payment-driven medical profession, we've got to have courageous conversations. Diane Mayer, an American academic, said last year that she thought we should stop talking about palliative care and dying and hospices because it put people off. I so disagree. I so disagree. We've made a few tentative steps of improvement and we mustn't lose them. We know that expressing your preferences, whether it be through one of the electronic palliative care coordination systems like Coordinate My Care or through advanced care planning, means that you're more likely to get what you want. And we also know that not spending money, for example, not giving people support in bereavement, is very expensive. A good study in Scotland reckoned that unmet bereavement needs cost about £20 million a year. We need a transparent public discourse. We need not to get out of step with the public. The Liverpool Care Pathway debacle showed us what happens when we do. And we've got that set of screaming on one side, driven by the media, Liverpool care pathway to death, and then we've got the assisted dying debate. And actually, professional voices are relatively muted in all of those debates. It was interesting to me that we had implemented gold standards framework, a toolkit that's very useful and very well known around supporting people coming to the end of their lives in a variety of settings. We'd implemented it into about 270 care homes. We had not had any complaints about the Liverpool care pathway bit of that implementation because we didn't call it the Liverpool care pathway. Because very soon after we started using it in care homes, years ago, because we were listening to the care homes and we were doing training over years, and because the care home staff were listening to the relatives of the residents, we were told that people didn't like the idea of a pathway. So we just used a different terminology. We need to find some balance and wisdom. We need to think about saying to people, if they say, I want to die at home, what would it take for you to be able to die at home? What can you and your family and community bring to that? And what can we bring to that? And how can we put something together that might work? We need to avoid ageism. We need to think about the role of telemedicine, about information and online patient forums. My daughter has type 1 diabetes. She's part of an international online information forum for people living with type 1 diabetes, and they know more about their condition, including some dinky little things that they purchase because the NHS and most healthcare systems won't buy them for you, and the manufacturer, they sort of insert under your skin. The manufacturer of them tries to make money by giving them a very limited shelf life, and this online group of people living with diabetes have learned how to circumvent the shelf life and make them last for quite a long time. That means that they're actually relatively inexpensive. We've got patient online forums who are unblinding RCTs. I'm not saying these are good things or bad things. I'm saying that as professionals, we've got to learn how to have a more sensible dialogue with the next generation of patients. And we need a shared conversation about appropriate risk. We've learnt so much about assessing risk, and we've forgotten how to talk about what we agree with the patient, the individual, and their carers, their family, their friendship network, and a conversation with us as the professional, writing it down and agreeing what's an okay risk. Because as we work more with frail older people, we will be working with risk. And some of those risks will come home to roost. And we've got to find a way of not getting into blame. We need to think about shared lobbying because government policy and regulation really matters. We need to think about developing emotional literacy in all sorts of settings, including employment settings. And each one of us in this room needs to think about our personal responsibility, about making a will, about thinking about our wishes. If we were to be coming towards the end of our lives, who would we want to speak for us if we couldn't speak for ourselves? What would be our priorities in terms of care? We need to think about these issues, and we need to talk to the people who matter to us about what we have decided, and it's a repeated conversation. We need to remember that care isn't a commodity. It is not a professional written prescription against a known set of problems. It is something that we create together. Good care means not only giving excellent pain and symptom control, it means understanding the meaning of the illness for the individual and for their network. It means finding a way to let them think about what really matters to them. It means knowing that we can't make dying not sad, but that we can make sure that no one is left completely alone with their sadness. Thank you very much.
Thank you. Well, I'm the research sandwich between the reality of life on the front line. So, hang on. Okay, so I'm going to talk briefly about research in end-of-life care. What have I done now? Okay, research in end-of-life care and how we can provide some of that evidence to improve care. I sit here. I don't actually sit there. For those of you who know the university, that's the chaplaincy. But it was the best illustration I could find of a local ivory tower. And that's the impression of many people about research. It is in an ivory tower, and it's not designed for people in practice who are actually providing end-of-life care to people out in the field. I couldn't disagree more. I used to be a clinician. Well, technically I still am a clinician. If you look me up on the NMC register, I am still there, but you possibly don't want me looking after you anymore. I haven't worked clinically for a while. Although my children will tell you I wasn't any good when I was clinically working as a nurse because all my patients died. So they clearly understood what I was doing. But when I turned to work in research, I did that because I still wanted to make a difference to patients, and I believe that research has the power to make as much of a difference to patients as I did when I worked clinically. So what I want to talk about now is what I've called the 5 pillars of research, which sounds rather grand, but really I've called them who, where, when, what, and why. A fairly quick romp through some of the issues that face us in research and researching people at the end of life, and some of the really gnarly things that we still need to grapple with. Who? So who should we actually be doing research with at the end of life? As Barbara has already alluded to, most of what we've done in the past has been with people with cancer. But in fact, if we look at why people die, they don't die of cancer. This is from the World Health Organization, so these are global statistics from 2012, just a couple of years ago. And actually you have to go down to the fifth, which is actually trachea, bronchus and lung cancer. That's the only mention of cancer on that. The rest of them are very much further down for the rest of the world. Cancer is not what most people die from around the world. When you start looking at UK statistics, and these are taken from the ONS, it's exactly the same. But what I've done here is take some of the ONS statistics and break them down by age. And you'll see very clearly then, as we start to look at it by age, that you die of different things depending on how old you are. But it's still very noticeable there that even in the only mention of cancer is in that 35 to 49 age group, when we might find cancer in terms of the malignant neoplasm of the breast for women. When you look at what older people are dying from, and that is most people, they're dying from heart disease and they're dying from dementia, they're not dying from cancer. So do we, working in the end of life and doing research at the end of life, actually understand how to care for these people that are dying from a range of diseases? Well, I think we probably do, although we don't realise it. This is some research drawn from some colleagues on the Euro Impact project, which if you see some of the posters out there, Lancaster University was involved in that project. And they looked at whether there were differences in the symptoms and problems that people had across a range of diseases, including cancer, but also looking at some of the other diseases like neurological diseases and dementias. And the quick answer? No. There isn't really a lot of difference. They found that there was great symptom commonality across diseases. So actually the skills that we have, both in researching people with those diseases and caring from them, should be shared. So let's look at some of the research, which is something that I did a couple of years ago, about whether actually all of those people are accessing palliative care services. And this is some work I did looking at community palliative care services, but not just specialist services, looking at generalist services as well. And I don't think it'll come as a surprise to you. The answer is no, they are not accessing these services equitably. If you're older, if you're male, if you're from an ethnic minority population, if you're not married, if you're without a home carer, if you're from a disadvantaged group, and if you don't have cancer, you're less likely to access all of those services in the community. We can see that from research. However, we've described that extraordinarily well. The reason I could do that review was because there were something like 50 papers, a pile about this big, that I actually had to wade through. And the conclusion I made at the end of that was, do you know what? As researchers, we've done the describing bit. We really get that services are provided inequitably. What we haven't done, and my call to arms at the end of that paper, which I wrote in 2008, it was published in 2009, was we need as researchers to move beyond that and actually to understand why there is this inequity, and perhaps more importantly, to do something about it. But sadly, when I looked at what was still needed, my needed slide, we just still don't really understand that. There are some studies starting to unpick that, but in terms of turning to the research evidence and saying, this is what we need to do to ensure our care is more equitable, we're not there yet. My next pillar was when. Clearly, when people are dying of different things, they die in different ways. And this is a very typical dying trajectory. These are actually the numbers of people that are likely to die in any GP practice. Okay, so you're probably going to have about 5 people dying of cancer with a trajectory where they might be quite well for a while and then become very ill, with much more uncertain trajectories for organ failure and frailty. We argue, therefore, that we should provide palliative care really quite early on. And if we turn to the research evidence, one of the most highly cited but relatively recent study is this one, which was conducted in the US, where they looked at early palliative care for people with lung cancer, so a very specific diagnosis. And what they found, unsurprisingly, that those people had a better quality of life, but what they also didn't really expect when they did this study was they were actually surviving for longer as well. So actually palliative care meant that people survived longer. There are some caveats with that. As Barbara's already alluded to, the US system is very different to systems in other parts of the world. And I know there are some studies out there at the moment. For example, they're looking at some of this in Denmark at the moment to see whether it's true in other areas. We're looking at some of that work in terms of when to provide palliative care and when to think about planning for your own death in one of our studies. This is one of our EU-funded studies, the ACTION study, and some of the people working on that are here tonight. And there we're trying to look at how we can better enable people to plan for the end of life in a very large multi-centre, multi-country trial. But what do we still need? We still really need to understand better through research how we enable palliative care to be delivered throughout that care trajectory. Where? Where should we provide care? My third pillar. Unsurprisingly, most of the people die at hospital. We've looked at the different diseases again. I've looked at some data that separates them out, but for most people, they're dying in hospital. But actually, because it's easy to measure, most studies look at dying in hospital, but we've already heard that actually where people are looked after and where they do their dying is more important. We know that irrespective of place of death, most people want to be cared for at home. But most people end up in hospital at some point. When you look at this, which was published just this year, it looked at everybody that was in hospital on a particular cohort over a particular time period. And what they discovered with that was at any one time, 1/3 of people in hospital will die within the year. So 1/3 of people in your hospitals right now in Lancaster in 12 months' time will no longer be with us. That means that wherever we might want to be cared for and wherever we might want to die, that actually making sure that hospital care is excellent is a top priority. We know, however, that home care is important, and a systematic review has actually shown that, thankfully, we're really quite good at it. We have clear and reliable evidence that home palliative care increases the chance of dying at home, however we might think about that as a metric, but also reduces symptom burden. And particular for patients with cancer, that's not to say that they're better at looking after people with cancer. Most of the studies with people with cancer are a real problem, without impacting on caregiver grief. So we know that home care works. But as we've already looked at, actually investment in home care, particularly in services like district nursing, is actually declining. So the research evidence is not being translated into action. A similar review looking at interventions for palliative care in nursing homes, sadly, not quite so successful, but partly because the research just isn't out there. There were 3 studies that they were able to look at in that review, and they were all from the US. So actually there's little evidence that interventions improved outcomes. So again, to make reference to another of our studies, the PACE study, another European study, one of the things that we're doing here in Lancaster is actually trying to understand how we can work with nursing homes to improve the quality of palliative care that they give. We're also thinking about settings in other ways, and some of the most innovative work we do is actually looking at people who are dying in prison. So the where is not home, but it is their home. It's where they live and probably where they're going to die. And colleagues, again, who are here today are looking at some of that work on settings, vitally important. We're also looking here about how we can actually provide care across settings, integrated palliative care, looking at innovative models of providing care. And this is the last of our EU studies I'm going to talk about today, which is INSUP-C, which is again looking at models of integrated palliative care. So in terms of the knowledge that comes from those, it's watch this space because we've only just started those studies. So what we still need is how best to provide palliative care where people live. We know that it makes a difference, but if you say exactly how am I going to do that, what model do I use, is it general palliative care or specialist palliative care, we still don't understand that. And my last 2 pillars are interrelated, so I've put them together, the what and the why. In terms of the what, I've actually chosen an example study here because it demonstrates a critical issue with some of our work in palliative care. It shows that studies on how awful it is to have X and what the needs are of people with Y dominate our research landscape. That's great. We do need to understand what people's problems and issues are, because if we don't understand them, we can't do something about it. But that next leap of actually trying to understand how to do that, how to provide practical and psychosocial support to people, in this instance with motor neuron disease, but I could have chosen any one of a number of studies that showed that. It's that next leap of how do we make the difference, not just how do we describe what's going on, which is really needed. When we look at the effectiveness of complex interventions, and some people have done a review of that, we can actually see that the effectiveness is moderate because we need to understand complexity. We oversimplify things in research teams. That's what we do in a standard randomized controlled trial where we're comparing drug A against drug B. That works as a method for those sorts of studies. It doesn't work in palliative care because the real palliative care world of real, messy, complex people with real, messy, complex services providing care for them. And we just haven't got to grips yet, although we're starting to do that in terms of how we do that in research terms so that we can help all of you to make a difference. I think we saw the impact of that with some of the hoo-ha about the Liverpool care pathway. And it's the research element of that I wanted to bring out. Did we shoot ourselves in the foot? Because what it said here in the independent review is that an independent prospective testing of the Liverpool care pathway has not yet been carried out 10 years after it was disseminated. If we're not prepared to do our own research on our own interventions, then we have to take responsibility for when things start to go wrong. But actually, we know that we can do those studies. One of the things that we were involved with is something called the More Care Statement, which is actually about how best to evaluate complex interventions. Yes, it's challenging, but it's not so challenging that we can't do it or have a really good stab at it. And what the More Care papers show is actually good practice in how to do that. We really need to think then about how we translate those findings into practice. There's a whole area of implementation science which is as real in hospice and palliative care as it is in other areas. We need to then take those findings and help people to use them to make a difference to people who are dying. That's the critical thing. There's no point me sitting in my ivory tower if I'm not going to take the work out there to make a difference. One of the reports that we've been involved with is a partner one to the one that Barbara showed, which is about research in palliative care. Can hospices afford not to be involved? I'm sure it'll become as no surprise to you to find that the answer is, do you know what? Hospices need to be involved. But my challenge to you is what we need is not just hospices, what we need is not just hospitals, what we need is not just community services, but we need everybody to be involved in research in palliative care. You can provide the ideas for research. You can help us with doing the research. You can certainly help us with disseminating the research and using it to make a difference for patients. Thank you. Oh, technology. Oh, PowerPoint's not responding. Marvellous. You could just dance amongst yourselves. You can wire yourself to sound.
I'll wire myself to sound. What do you reckon?
There we go.
All right. That was a heart-stopping moment. As I follow with some trepidation Dame Barbara and Dr Catherine. I'm Sue and I'm the Chief Executive of the local hospice, St John's Hospice in Lancaster. And I, about a year ago when I met Catherine, I talked to her about how as a local hospice we could be a better partner for the university, and she said just do some practical stuff. Help us to really put things in practice. So today what I hope you'll get from me is some practical stuff. I was asked to talk about the history of the hospice locally, to talk about where we are presently, and to have a kind of glimpse into the future, a scan of the horizon based on all this research and amazingly useful stuff that's come out of the commission at Help the Hospices, and to just kind of practically tell you what we're doing with it in Lancaster. So, the history is that we're about to celebrate a big birthday too. So the university's 50 and another great social community asset, the local hospice, is about to be 30. We officially opened in 1986, so we're approaching our 30th anniversary. So we're doing a fair amount of, looking back and reflecting and looking forward and thinking about where we're going. So it's really timely that we stand here. So when I was asked to speak about the history, I went to look for it. And what I found very interesting was it's not really recorded very well. So I thought, well, I'll take myself back to the 1980s, which was lovely, because I felt very comfortable there. And in 1986, when the hospice was launched, if you like, what was happening in the world that meant that this great social movement took place? So 1986, for those of you that remember that far back, 1986 was the end of the miners' strike. When we talk about working in partnership now, the ultimate partnership was forged because we signed the contract for the Channel Tunnel. Who would have ever thought that partnership would happen? What else happened? The Wapping dispute happened, actually. And for me, that was quite timely because a year after 1986, 1987, I had my first job on a local newspaper. I should confess here, I've never worked in the NHS. I'm not a clinician, but I can run a business because I had this cracking first job. I worked at the Guardian Media Group as a management trainee, a year after the whopping dispute had turned the newspaper industry absolutely on its head. So we'd gone from, you know, a very traditional unionised industry where men set papers on hot presses to we press a button and it's done electronically, and where 300 people used to produce this paper, one person now can do it. So a kind of massive change in this industry in 1986. But what we knew on a newspaper, and what you had to know, because you weren't allowed to walk in the building on Monday morning without knowing this, you had to know how many papers you'd sold that week, how many people in a household read them, and if they read our paper, what car they drove, what house they lived in, and where they might go on holiday. Real demographic information. You knew your customer and you knew who you were dealing with. And I think that's really interesting, because I'm not absolutely sure as I enter this sector, and I've only been here 3 years, that we really know which way's up in terms of demographics and data and knowledge. Okay, but I digress. So, the history of St John's Hospice, that's what's happening. That gives you a feel of it. And I probably would have been dressed like Lady Diana or Madonna in 1986. So imagine that. But the one thing that I'm going to give you at the end of this is the song that when our hospice opened was #1 in the charts for 4 weeks. And you have to guess it. Okay? You've got to guess it. The theme is threaded all the way through this presentation, because when I worked out what it was, I couldn't actually believe how appropriate it was for the 30 years of a hospice in this community. So if you can work it out by the end, you can give yourself a pat on the back. But I'll play it for you at the end, by the way. So, our glorious past. We've had a glorious past for 30 years, and here is the past. I was asked to give you the history. Here's the history. In 1952, an order of monks opened the St John of God Hospital for the Chronically Sick in Silverdale. And for those of you that don't know where Silverdale is, it's a few miles up the road. It's a beautiful village right on the edge of Morecambe Bay. It's a beautiful place to open a home for the chronically sick. But it's a big old drafty building, and in 1968, the monks moved on and the nuns took over. And if you went to the kind of school I went to, and maybe you didn't, you might have a view of what nuns might be like running a hospital. But actually, the missionary sisters of Our Lady of the Apostles should not be underestimated. These women had seen the world. They'd lived in the far corners of the world as missionaries. They were amazing women. In fact, Sister Amy Cox, who was our founder, ended up in Silverdale after 25 years working as a missionary midwife in Africa. So can you imagine the culture shock that must have been? But this is the woman that kind of, in 1968, went to Silverdale and probably was watching what Dame Cicely was doing down in London and thinking, hang on a minute, this drafty old building's not right. And in actual fact, that's how the movement started here. By the 70s, the building's no longer fit for purpose. Sister Amy gathers the great and the good of the local community, including the richest man in Britain, the Duke of Westminster, who at the time was our patron. And she organised the first meeting of the Board of Trustees. So the 6th of May 1980, the Board of Trustees get together, they apply to the Charity Commission, and they estimate it's going to cost about £1 million to build what we now know is St John's Hospice on Sline Road. And then Sister Amy did what we absolutely know in our hearts we should do every day when we're doing something that's a big social change. She called a public meeting. She didn't mess about. She just got everybody that she could get into Lancaster Town Hall. And this happened on the 1st of October 1981. It was advertised as a mass public meeting to ascertain the appetite for a hospice in Lancaster. Now, bearing in mind, when I was telling you about 1986, this was not a time when people were feeling affluent. In fact, we had the worst unemployment figures in 1986 than we'd had since the war. It was a time of real austerity. So she knew she had to do this hearts and minds stuff. So she organised the meeting, and this is a minute that you don't see on very many council minutes. It actually says in the council minute, the plans are met with the full approval of all present. So she's going to raise £1 million. She's going to build on a piece of greenbelt land in the centre of the city, and she gets everybody behind her. It was great stuff. So 1984, the building begins. One of the amazing things that happened at this point was that the council wanted to gift the land to the hospice. And the trustees, led by Sister Amy, said, no, we want to buy this land off you. And I am ever so grateful that they did. They paid £60,000 for the land, and she wangled a deal to get £30,000 back as a grant. But I am so glad she did, because when I visit so many hospices and they're hemmed in by building work around them, Our grounds are one of the beautiful things about St John's Hospice. If you want to visit, you're really welcome to visit us if you haven't been, but it's an oasis in the centre of the city. It's on the main A6, but when you are in our inpatient unit or at the back of our hospice, you could be in the middle of nowhere. It's beautiful. And that was inspired decision making to buy that plot of land. And really, if the council had gifted it to us, who knows what it might have been now. It might have been a building estate, mightn't it? So, 8th of January 1986, St John's Hospice is officially opened by the Duchess of Norfolk. It actually cost £1.5 million to build, and we had 28 beds, but it really doesn't matter because you know what? The Health Board fully fund the running costs. And that sounds great, but I think that's left us with a bit of a legacy of complacency. And you will see when I bring you up to date how we've never quite recovered from this thinking of it's okay, we'll be provided for, the money will come. So there's our history. So 1986 is fine, 1987 is fine, and then in 1988 this happened. Things get tough. These are press cuttings from the local paper, the Lancaster Guardian. Hospice may face closure, the hospice fights for survival, and those of you that live locally will know that all those headlines are here again at the moment. And this is because the statutory funding was cut by 10%. So 90% of the hospice running costs were going to be funded, and this was because of a wrangle between the Lancastrian Health Board and the Cumbrian Health Board, and it was ever thus. You know, we're still having those arguments about who pays for the patients from Cumbria and who pays for the patients from Lancaster. And these little headlines made me laugh. One of the friends of Lancaster Hospice said, how can we possibly guarantee raising more than £10,000 a year? And on Saturday just gone, we had our Ladies' Moonlight Walk, which one event on its own now has to raise us £100,000. So it's interesting times. So to bring you up to date, it's still tough. Presently, the hospice, and I arrived probably about 18 months ago. When I arrived 18 months ago, it had a £500,000 deficit, a gap in our income and expenditure. And £500,000 is pretty significant when you're needing £3.7 million to run. It's a big chunk of money missing. And we do have some reserves, but we've got about 9 months worth of reserves in the bank. So we can't carry on forever running at a loss like that. So we've had a real year of looking at how we do things differently, doing more things in partnership, not paying for everything, cutting the costs. And I'm really delighted to say that the year we've just put to bed financially, we were so close to breaking even though we were budgeted to be still about £470,000 overspent. But we are doing so much better because we've gone back to the principle of bringing the public with us, telling people that we need help, articulating what the hospice is about, and explaining our charitable status. 30% funding from the NHS, plus some other work that we're commissioned for, but there's no guarantees with that. I couldn't tell you whether we'll still be funded by the NHS next year. Those of you who know hospices will know that from October this year, we're going to be regulated by the Directorate Social Care rather than the NHS. The CQC regulation will be taken over by Adult Social Care. The three things that are on the horizon right now are competition. So commissioners are bundling services together. End-of-life care doesn't get the precedence it needs on its own in some places, and in other parts of the country we're seeing bundles of elderly care bundled together, and end-of-life is just lumped in there with that. And I think that's our job, is to go talk to commissioners about why things need to stand separately. Expectation. One of the most tricky complaints I've dealt with in my career really happened this year, and it was a family who really couldn't understand why I was, and these were their words, throwing their father out of the hospice. Because after 2 weeks, symptoms had improved and he was much better, and it was time for us to send him back to the care home where he'd come from. But the family complained to me and said, he likes it here. He can have a gin and tonic at lunchtime and at tea time, and he likes the fact that the dog can come in, and the nurses have got so much more time, I want him to stay here. And actually, you know, when we take him to this care home, it's £900 a week. An expectation, and at first I was thinking, gosh, I'm quite cross about this, but actually what I realised was it's us not articulating who we are and what we're about and how we're funded. So expectation is a big thing. Regulation has a massive impact compared to 30 years ago. When I look at my bottom line and the deficit there of about £200,000, I have £200,000 worth of jobs with on costs in my bottom line of what I call management factory. So things like information governance, IT support, HR support, quality and the quality agenda, you know, making sure that we're right for CQC and that the policies all have an equality impact assessment. All necessary things, but it's the management factory and it adds another £200,000 to the bottom line, and regulation changes the way we work. And I'm going to sum it up by showing you this picture. The first picture is Sister Amy topping out the building in 1986. And she's clearly shimmied up the ladder there in a full nun's habit and open-toed sandals, and she's slapping a slate on the roof. The second picture is us topping out the new Hospice at Home Hub building earlier this year. And if I tell you that there's probably only about 3 of us in that picture, and the rest were the people that carefully taught us to climb a ladder. We had special shoes, we had yellow jackets, we had goggles, we had gloves, we had to learn how to keep one hand on the ladder at all times. And that's the kind of regulation that has gone a bit too far in my opinion, but hey-ho. So the future. What is our challenge and our opportunity, our mission and our opportunity, if you want to use the Commission's words? We sat down last night with the board as a senior management team, and we really went through the toolkit. It's a really useful toolkit at the back of the document you've already seen. And we went through the things that are going to make the biggest impact for the future for St John's Hospice locally. We know we need to deliver services in the most efficient and effective way. There's 160,000 people in the Lancashire North CCG population area, and there's about 100,000 people that we deal with in South Lake. So 260,000, and 1% of them are going to die every year. And when I think about the way we record what we do, we don't show our activity well enough and clearly enough, because all we record is that we dealt with 425 deaths. But, you know, that doesn't look like a great reach, does it? It doesn't look like we're touching lots of lives and lots of families. But we know we are in other ways. The other way that we want to kind of increase our reach is by using volunteers in clinical positions. And we're hoping to get some grant funding to help us look at that this year. Because going back to where we started, that's absolutely what we did. People that have been around in the organisation for 30 years tell me that volunteers used to help lay dead bodies out. You know, they did everything in the hospice, and now we've kind of regulated everything, and you've got to have registration, and only professional people can do that. And that fear of people doing jobs that, taking jobs off people is a real fear, but we're going to try and push the boundary this year and see how far we can go with volunteers. We have to ensure we're the charity of choice locally. People do want to support us. Until I came, if I had £1 for every time people said to me in the street, I didn't know the hospice was in trouble, I could have fixed the deficit. But, you know, we'd not really done a lot of communicating where things had gone wrong for us, and we can't be lazy with that. We must be a welcoming, creative and effective partner. This is the only way we're going to have any relevance in the future for me. It breaks my heart that until 18 months ago we had no real relationship with the university. We'd had one, but we'd let it wither on the vine and die a little bit. But we've rebuilt that now, and we're starting to do some great work with some of our nurses who are real ambassadors for research, and some of the doctors who are in the audience tonight. And we're really building those relationships around research and being a great partner there. I'll tell you about 3 other partnerships that we've done this year. We had a fantastic Dying Matters week in Lancaster, and that was completely done in partnership with a few willing people who really wanted to have an amazing week, and we absolutely did that. The other partnership, which I was terribly fearful of, was our 24/7 Hospice at Home hub. We're the palliative care hub for North Lancashire at St John's Hospice. 7 in the morning till 10 at night, our nurses man it, and overnight Marie Curie Cancer Care come into our building, use our facilities and provide a rapid response service from our building. And I was terribly nervous about that partnership because I used to work for Marie Curie, and I kind of imagine this army of marketeers coming up the M6 and taking a slice of the pie. But it's not worked like that. The thing that's really happened is patients and families get a great service. And in fact, last year, 12,500 home visits were made by that team, and 10,000 phone calls were taken. And that's just our bit of the team. It's doing amazing stuff. The other innovative partnership that we've had this year was There are 31 hospices in the northwest region, 31 of us. In fact, there are 5 within an hour's drive of where I'm standing right now. And when I started at the hospice, I couldn't quite believe that we never worked in partnership at all. And there was another fabulous report from the Help the Hospices Commission, was Strength in Numbers, and it was about the power of fundraising and why those big national charities have the edge on hospices, because they're prepared to spend some money and use their budget wisely and do TV campaigns. You know, have you ever seen a local hospice on the TV? Well, this spring we were, because I got in touch with all 31 hospices and said, come to Granada TV, they're going to talk to us about how collectively we might do a regional TV campaign ad. And we went down there, and by the end, some people dropped out because they get bored of TV up in Cumbria somewhere. But most hospices took part. 27 of us paid £1,600 each, and we had 30-second adverts telling people what hospices aren't. Which, if you do a job like mine, it's what I spend my whole life doing, telling people that it's not all about death and dying, it's not just about cancer, you know, and it doesn't all happen in the building on Sline Road. So we had our advert, and that partnership of 31 hospices, we're going to review what we did, and in July, in a couple of weeks' time, we're looking at the next campaign. But you can't do that standing alone as a little perfect silo. So we are really trying to work in partnership with other organisations. There's no doubt that for 30 years it's been tough, and I don't think it's going to get any better. Tough is the theme. But we have to look forward. And when we do that, we have to consider what our timeless guiding principles are. What's sacred, what's not? What are we leaving behind, and what are we taking forward for the future? Our timeless guiding principles, our values are care, compassion, collaboration and charity. And we did a session where we tested those values with patients and families, and we talked to people and said, when you come in here, does it feel like this? Can you sense this? When you come into the hospice, is this how it is for you? And we've added one, and we only added it last night at the board meeting, because one lady said to us, I want you to add a word, and the word is celebration, which seems a bit strange, you know, and we asked her to tell us more. And she said, what you do at the hospice is you celebrate the things I still can do. Everybody else focuses on the things I've lost, but you celebrate me and the things I still can do. And when I die, I know that you'll celebrate the fact that I was ever here at all. And that's one of those moments where you think, you should always ask the patients and families. So we've added that to our list of values. So timeless guiding principles, what's sacred and what's not. A perfect example of that is our move away from a very chaplaincy-led model to a model of a spiritual care coordinator, because when we look at the data, very many of the patients we're caring for now don't have any particular faith. Still spirituality, but not a faith as such. So we have a coordinator who has access into all the faith groups we might need, but does a different job than a chaplain would do. Just one example. Opportunities to influence, so commissioners and communities, and if you can't influence a commissioner, go and influence a community, because in the end the commissioners have to ask the communities. So you know, there's a way round influencing really, you just got to be savvy, political with a small p, and I kind of think that's the job of a chief executive in a local organisation. Understand the demographics and data. It breaks my heart that the only national benchmarking tool that hospices have is the National Council for Palliative Care's minimum data set. And we've just had the return, and everyone's cheering because there's been a 66% return. I think that's shocking. Absolutely shocking that we can't benchmark nationally because people don't bother to return it. So understanding demographics and data, I think, makes us better for the future and facing the competition. Governance. Teams and boards must be fit for the future. In the 18 months that I've been at St John's, we've had some pretty senior changes, serious changes at senior level. We've also had a 40% turnover on our board and a change of chairman. And what we've done when those changes have happened is we've looked at the gaps. And in fact, last night, in the light of what we've seen in the commission documents, we actually had a conversation about, so here we all are now with some new people and some new blood on the board. Where are the gaps? What do we need next? And you really have to have those conversations, and the tough conversations about the people who've been there just a bit too long. People need to move on. So Hospice 2046, will it still be in that beautiful garden on Sline Road? It's difficult, isn't it? Because there is a hospice in the south of England that tried to close its inpatient unit just recently, but what it didn't do was the public engagement bit, and they've had to turn the decision on its head and keep the hospice open. You have to really you have to make things a yesable proposition by taking the community with you. I think there'll be more mergers. 31 member hospices in the northwest is bonkers. 5 hospices with a £20 million income and £20 million in reserves, just 1 hour's drive from standing here right now, is bonkers. Together we have so much more power, and we really don't use that to our best services, really, for patients and families, in my view. So I do think things will change, and I think statutory funding may well completely disappear or may well come from other avenues. So it's tough. It's been tough for 30 years. I can't imagine it's going to get any easier, and it's certainly going to be tough in the next few years as funding decreases and there are more charities in the market. I'm going to leave you with some images of the 30 years that we've had, so past and present. I'm absolutely determined that St John's Hospice is going to carry on being a movement and not a monument. I really hope so. But we are going to have to be flexible, and we're going to have to adapt. I'm going to leave you with this song. Have you worked out what it is yet? I'll play it for you. Listen to the first 4 lines. It's almost like it was written for us. So this is number 1 as St John's Hospice opens in 1986. Did you guess? Oh, what a shame.
It worked perfect when we tried it out.
Why is it not working? I've got something to tell you. I've got something to say. I'm going to put this dream in motion. I'm not going to let anything stand in my way when the going gets tough. Exactly.